Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine so that you and your practice can thrive, be profitable, and successful for years to come. So today we're going to focus on telehealth and are here to ask certain questions. Number one, telehealth, is your practice taking it seriously, or is this a public health emergency stopgap? Also, what are the physician fee schedule telehealth changes when we talk about Medicare? And with many patients that can only participate in audio-only telehealth, how will this change your adoption of telehealth in your practice post-PHE future? Well, those are some of the topics we want to tackle today. And with those topics, I have with me Grant Huang of Doctors Management. Grant brings extensive knowledge to his role as Director of Content at Doctors Management. He produces educational products that help ensure that auditors, coders, practice managers, and administrators optimize their organization's revenue cycle while improving their compliance in today's complex regulatory environment. Grant is an auditor with proficiency in multiple specialties and also has experience in healthcare analytics, including benchmark provider billing patterns. Grant, welcome to the podcast.
Thanks, Terry, and I'm happy to be here with you today.
Great. We are very happy to have you. And Grant and I have we've gone back and forth on some of those Medicare office hours calls. And as soon as I write down a question, he asks the question. So it's almost like you hear what I'm thinking.
Yeah, well, a lot of the time I find that those are one of the few opportunities we have in the industry of getting a straight answer, more or less, out of CMS. And, what we are not journalists, so to speak, but we are in the position of kind of trying to clarify and communicate all of these things about complex, regulatory stuff to the provider and administrator community. And it's hard to get definitive answers from CMS on stuff. So much of what's put out is stuff that you have to interpret. And so when we're able to ask a question of CMS and you have some CMS official on the other end of the line say, well, here's my response, then of course you and I immediately write that down and we can point to that and say, well, look, here's what the agency has officially said, about X, Y, or Z.
Exactly. And it's actually tough. And you brought it up too, as educators and auditors like we are, and also people who are out there writing articles and blogging on the topics. Sometimes we feel like we're out on an island and we're not able to have conversations to address some of these telehealth questions that come up with our physician clients, with many healthcare professionals. And I think there are many medical practices that are operating on what they're doing now and haven't really looked or have had time to consider what they're going to do post public health emergency, so post PHE. So with that in mind, you and I both have participated again in those Medicare office hour bi-monthly calls, and we seem to be the only ones asking the question about originating site, even though in one of the publications out there we were talking about Part B News. They have started finally talking about the place of service of where the patient is. But I have a question for you. What are your thoughts on the 2021 physician telehealth changes in the fee schedule, and which services will stay and go under those Medicare coverage rules are you anticipating or projecting?
So first off, like you said, some of the most consequential changes or waivers, I should say, that are in place for the duration of the public health emergency are things that will go away once that declaration ends, including the originating site waiver. And obviously that's a huge one. If you look at the history of Medicare coverage for telehealth, it's always been bottlenecked by this restriction on originating sites. And, for the longest time, the advocacy groups that have lobbied to change this, like the American Telemedicine Association, they've always tried to fight this, and it really took a pandemic to finally get the government to kind of drop that. And as a result, we've seen the telehealth utilization explode, and that's something that's simply not going to be preserved without congressional action, without federal legislation, because CMS does not have the statutory authority to maintain that waiver after the public health emergency ends. And they make that clear, in the final rule. They've admitted, as much on some of these open door calls that we've been on. So with that out of the way, and we can always hope that as proponents of more patient access to care, we can always hope that the Biden administration might take a look at that and maybe promote that. I think telehealth, hopefully, the benefits of it at least, would be a bipartisan issue, an issue that there would be bipartisan support for. But as far as the final rule itself, they tried to preserve as much as they could, I would say. They came up with 3 categories for telehealth services, one being the category of services that will be removed from Medicare's telehealth eligible list when the health emergency status ends. The second category will be those services that are temporarily added to the telehealth eligible list, and they'll actually be in effect through the end of the calendar year in which the public health emergency declaration ends. So, if, let's just say, for example, the PHE ends at this year, let's say it ends in September, I'm just making this up, that these category of codes will actually continue to be in effect until December 31st of this year, which would be the year in which the PHE ends. So the idea there from CMS was to give itself some time to gather more data to determine whether or not these services should be permanently on the list. And these temporary additions would include things like critical care services, inpatient neonatal pediatric critical care, end-stage renal disease monthly capitation payment codes, emergency department visits, a lot of these things that you could sort of see a case for telehealth. But you have to think about what it means from a utilization standpoint, from a cost standpoint, to a budget limited program like Medicare, which is why I think they want to see, are the costs offset by the outcomes? Is it going to result in an overall increase in utilization and expenditures that just wouldn't be sustainable?
I agree. I think one of the things that I'm having a hard time wrapping my head around is the fact that everybody thinks there's kind of an open-ended checkbook when it comes to Medicare. And because we've seen the explosion, and like you said, it was necessary under the public health emergency, no question. But the one thing that's tough is that, and I'm hoping the fact that telehealth got put on the OIG work plan for 2021, this is what they're looking at before any kind of knee-jerk final adoption as far as the place of service. But is it being done because of convenience, or is it being done because of effectiveness? I mean, rheumatologists are saying that telehealth doesn't work for them, and oncology says it's really hard to do telehealth. Even cardiology is having some issues. Mm-hmm. And so I just believe that it's a great addition to a practice, and it's definitely helped a lot of patients that couldn't have access otherwise, like you said. But I think it's also, and we've seen this with the the announcements we've seen on OIG, it's caused some fraud schemes, it's caused some overutilization. And I had a practice the other day just tell me that, well, now that my nurse can go ahead and call patients and bill for office visits. And I'm like, whoa, wait a minute. Your NP or your RN? No, my RN, she's been here 20 years, so she's just like an MP. And my head exploded. I'm like, okay, back the train up. Like, And the doctor was basically saying that, she's basically just going around calling patients and charging for phone calls, and because she can now. And I'm like, no.
Yeah. I don't doubt that an RN with 20 years of experience could handle some of these cases over the phone, but obviously that's just not the way the rules work.
Exactly, and that's the thing; they're not qualified healthcare providers, professionals. So So moving on with what you were talking about, let's just project once the PHE ends. And I know right now for those listeners that are on It says right now on the PHE.gov that it's supposed to end April 21st. Well, what it
Right.
says, it was extended till another 90 days, so through April 21st. I would probably guess they're probably going to extend it again if we don't see a huge decrease in
Oh yeah.
COVID
Yeah.
cases. But let's just say that it ends at some point, like let's just project the fall this year. You know, platforms that they've allowed under the CARES Act, the Skype and the FaceTime, don't you agree that they'll not be allowed because they're not HIPAA protected?
Yeah, that was another, crucial waiver, and that hasn't even been enough to increase access to certain patient populations. But the way it was phrased as a waiver was simply that the OIG would choose to exercise its discretionary power not to enforce HIPAA for cases where a non-secure, non-encrypted, two-way video audio communications platform was used, so long as there's documentation showing it was done in good faith. Was the term.
And that's funny that you said that, because I had a conversation with somebody recently who actually just got their first audit request under telehealth. Boy, they really rolled that out quick. And I also audit for some Medicare Max. And they basically said, we're being audited. They're asking us for 30 records per physician. And I said, well, they must have seen some kind of a utilization issue. And they said, well, what does it mean that the letter we got says that we're checking to see if you acted in good faith? And I said, well, remember, that's the OIG and CMS definition of good faith. What they feel was medically necessary, not necessarily what the physician felt it was. So this could be an interesting kind of concept as telehealth is being audited. But the other thing you said, the OIG said on the Skype and FaceTime is that they would not enforce a rule that's already there as long as it's good faith. But I still have my clients put in the record that the patient was informed that this may not be HIPAA protected. What do you say?
Yeah, and I think that's very smart because we don't know precisely how they might choose to define good faith when it comes time to audit this. There's certainly, and the best practices that we've recommended too are things, kind of basic things, common sense things, but nevertheless, you should codify these things. Like, for example, if the physician's going to do telehealth encounters in the office or even at home, obviously you should tell them to keep the door closed so you don't have other people walking in when they're on with the patient and violating that patient's privacy. You should document that the patient was, like you were saying, offered a secure platform if you have one, and you should have one if you're doing telehealth, certainly before the pandemic, but even after. There are these secure clinical platforms that are out there, and say, well, it was the patient didn't have access to that, and there was an emergent need in the pandemic for them to just hop on Skype or what have you. I think that those are all good things good practices to follow from a compliance standpoint. And it's not mandated, of course, but whenever the government gives you a certain amount of rope, you don't want to hang yourself with it. You want to use that as carefully as you can. And I think since my background right, my background is a lot in compliance, and you want to be careful when you can.
Exactly. And the other thing is too is I think, and I always bring up this comment whenever I'm talking to somebody about, or a practice or a healthcare professional, about things that are done that become habit forming. So for example, when you have something like for example, when an employer gives somebody a vacation, they usually give them a vacation for 2 weeks, because then after that, people don't want to come back to work because they're like, well, I've been off for 2 weeks. This is great. So it's hard to do that. Well, we thought the pandemic, remember that whole last March, 15 days quarantine to slow the spread. And now we're going on a year. And it's going to be hard to roll back things. I mean, in the words of Seema Verna, she basically was like, you can't put the genie back in the bottle. But in saying that, patients are going to have to realize that once the PHE ends, we have to get back to what a flexibility doesn't have. Will practices now put in that approved software, or will they get HIPAA protected patches for their already in place EMR system? Do you think they'll put in the expense and continue, or do you think it's based on patient population?
I think it could be based on patient population. I think if they were going to do anything, they might take the smaller steps first that wouldn't require an act of Congress. Something as seemingly uncontroversial as eliminating the originating sites rule has to go through a budgeting process. There have to be projections on would it increase the costs of the program, and then it starts to get political when there's money attached to it. And they never passed anything standalone anymore. It seems like it always gets latched onto some other bigger legislation that has nothing to do with it.
Exactly.
So there's no, I wouldn't bet anything on the originating sites thing, even though, again, it seems like a nonpartisan and non-controversial issue. On things like if you're a practice that has really gotten your patients to buy in to telehealth, and you have your patients who are willing and happy to engage on telehealth and feel like they're getting something out of these remote visits, then I think it absolutely makes sense to look into the steps you can take now while you still have the waivers to transition to a point where you can continue to do a pretty good volume of telehealth services, and just assume that a lot of these waivers are going to go away, and you're going to have to invest in a secure HIPAA protected platform, and you're going to have to invest in a patient education and outreach to teach them how to use that platform on their end, and you're going to have to look at, are you outside of a metropolitan statistical area so you can comply with the originating sites thing.
That's what I've been trying to explain to a lot of practices too, is they say, well, look at all the things that are covered now under telehealth. And I said, it's under the flexibilities. It means that those things still may be covered, but the qualifier on where the patient is what's going to be rolled back. So you still may have, category 1, 2, and 3, who knows, but the qualifier is what's going to be tough. So you can have all these things that are, covered, but that means that patient isn't in one of those, HRSA areas or metropolitan depressed areas, like you said. And I think the one thing that was put in the final rule, well, I know it was there, was the fact they are going to roll back audio only. And they have created a HCPCS code for that, but it's definitely only for one audio only phone call, and there's rules on it. Because I know that the phone call codes were never covered before. It was a gift now, and they just don't have the funding for it.
Right.
Yeah. So let me move on to, we're talking Medicare, what seems like, because Medicare, and just so the listeners know, the reason that we always talk Medicare is because Medicare, it clearly defines it in their rules. Medicare is out there. Most of you probably have a 30 to 40% Medicare practice or higher. But what about the commercial plans? I think this is probably the most frustrating for most coders, billers, professionals, physicians, any practices, because there's such a wide disparity in coverage guidelines by the commercial payers, not only for audio-only services, but for telehealth adoption. And it's all different, even down to the coding, the modifiers, how you report it. And for example, I have Blue Cross Blue Shield of Anthem. Prior to the PHE, they would call me every 6 months and say, you haven't utilized your telehealth benefit. And I'm like, well, I'm not sick. I mean, they were almost like saying, why aren't you going to the doctor? They said, but there's no co-payer deductible. Do you want us to set you up with our panel physician? So I didn't even get to use my own physician if I wanted to exercise the benefit. And I said, no, I'm good. And they called me a couple times. And then during the PHE, they opened it up to your own doctor, and they were clear that's temporary. So your thoughts on how that could change in the future?
Yeah, well, you make a good point about how there's been just a hodgepodge of various commercial payer policies, and some hew pretty close to Medicare. Others have been surprisingly generous with their telehealth coverage. You have some payers that have completely waived cost sharing for telehealth visits for in-network providers. Some that will waive it if it's COVID related, some that will just waive it period to encourage patients to get that care without risking anyone getting infected. And you have a lot of diversity in which commercial payers will pay for true telehealth visits. Like a 99213, you're going to bill it as a 99213 with a telehealth modifier. They're going to pay for that as an audio only service. Whereas Medicare strictly does not. And Medicare has a lot of statutory obligations that limit its ability to do that. But of course, these commercial payers have no such restrictions. It's just how they want to package their product and market it and say what benefits people get. And that's created a ton of frustration. Of course, not new if you're in the billing world, where you have discrepancies between payers and you literally have to post a cheat sheet of payers with their specific rules for specific, coverage policies. And a lot of the stuff that I mentioned as far as these benefits are time locked. Like, for example, Anthem has said that they're going to cover. They have this virtual text feature on their smartphone app, and their first 2 sessions you do that for any reason are free through the end of 2020, and then after starting now, they're going to charge for it. You don't get 2 free sessions anymore. Some of these cost sharing is waived benefits also expired at the end of 2020. Some were renewed. Some are tied to the duration of the public health emergency. So there's just a lot to keep track of.
There is. And also for the listeners out there, Grant mentions a good point, the hodgepodge out there, because they don't always inform you. You actually have to find it on their website on what isn't happening and what they've rolled back. The cost sharing is a big thing. At the height of the pandemic, last spring, a lot of the payers were panicking, or I should say buying into the whole let's do whatever we can for patients and not have them have an out of pocket.
Right.
But then as soon as we got into the fall and actually the numbers went down before the spike again in, last month, they basically were like, well, we're not going to, now we've rolled back where the patients do now have an out of pocket. So I have found that a lot of payers, you actually have to go to their website to find that information.
Yeah, and the whole copay waiver, cost sharing waiver thing can occasionally be a double-edged sword. There's a practice that asked me about their situation where they weren't aware that their commercial payers they participate with had waived copays for these telehealth visits and COVID screening. But so, like, if they come in person and the visit results in a diagnostic test order for COVID screening, that visit gets waived. The copay gets waived for that, and they weren't aware of it, so they were collecting copays for patients for all of these services. And now they're in the position of, we got a ton of copays here that we weren't supposed to have held on to, and the practice manager's wondering, can I, kind of hold on to these? And, when the person comes in, we'll say, hey, this one's a freebie because we already owe you, or do I have to send checks back out? And obviously, they have to, and that's going to be, time and effort that's spent on that.
Well, and I think the other thing that there was a lot of misinformation. I mean, you saw how often the FAQs with CMS was updated. It started at 33 pages, and now it's up to like 166 pages because they kept saying, oh, but this, but this, but this. But one of the things is that I remember sitting at my kitchen table sometime early April, and the government officials were, obviously giving us those briefings almost every day. But they were basically saying something to the effect that all telehealth was out of pocket was waived, and that wasn't accurate. What was waived is if it was COVID related, like you said. And then that means that the allowable for Medicare was 100% and the patient didn't have an out of pocket or a copay. But if it wasn't COVID related, you have the option under the CARES Act to waive it, but you're not being reimbursed by anybody. So you're only getting your 80% of allowable. So I think there was a miscommunication or a misunderstanding on that as well.
Yeah, and that again, those are things that were happening so quickly because, like you say, there was just this regulatory blitz where they were releasing stuff literally every week, sometimes a couple times during the week, which would amend what was previously released. You look at the last 2 weeks of March and then the first 2 weeks of April. There's a lot of changes that we were struggling to keep up with in releasing guidance to our membership and our readers at Doctors Management.
One of your colleagues at Doctors Management, Sean Weiss, who's also part of our NACHBC, him and I were tag teaming on different articles we were posting on LinkedIn because it was just crazy as far as how that was. But one thing I wanted to pivot a little bit. Remember, everyone, the height of at the height of the PHE. So again, last March, and again, we have seen spikes, but now that the rollout for the vaccine is here, I am starting to see reports about the decline already, not just in deaths, but in ICU. I know it's gotten a lot better in California. We're able to relax some of the opening situations, but at the height, telehealth visits were at 60 to 70%. That's pretty high. And now I'm thinking they're going to decrease once this is over to about 10 to 15%. So I think that's something you have to think about as well as you put this expense into your practice.
Yeah, I think it's I think we should acknowledge that the specialty of the practice and types of conditions and patients that they see affects the extent to which they're adopting telehealth. Like you mentioned, I think earlier in the conversation, rheumatologists have not used a ton of telehealth because many of their established patients have to present in person to be infused or to receive subcutaneous injections for their chronic conditions and pain management. And telehealth is just nothing to do with those needs. So a lot of rheumatology practices were not doing a ton of telehealth. And then just yesterday, I was speaking to a rheumatology practice that after they had a huge spike in COVID cases in their county, their doctors decided, you know what? Yeah, we'll continue to do the infusions side of the business because, we have to, but we're just going to have a policy that mandates telehealth for any other kind of visit, including new patient visits and anything where we don't need to actually infuse you or inject you. It's going to be telehealth or just reschedule, just because they had such a high risk of infection.
And that's actually, you brought up a point about the new versus established patient. One of the other things that was under the CARES Act is allowing new patients to be seen under telehealth. Remember, once it gets rolled back, it's an established patient benefit, except in rural areas. And so if it's not in a rural area, it's established, which I actually agree with. I think once the physician actually gets a patient in under a new encounter and then can build a profile for that patient, then allowing them to be seen under telehealth after the fact, to me, is for me, best practices and the safest way. Under the PHE, I understand why they allowed the new patient visits, but right. I can see why that benefit was there as well. But also, we've had some craziness when it comes to who wants to bill for telehealth. I mentioned to you, I think in our first conversation, I had an acupuncturist call me. Now you tell me how that works. When I see the PT and OT, occupational therapy, I can kind of get. But physical therapy, there are certain benchmarks you have to hit with strengths and weaknesses and improvements. And if you've got a pediatric patient, the parents, it's kind of like trying to teach at home through Zoom. Kids are struggling right now. And I think on the medicine side, I think that there's a struggle too. And I know oncologists are saying that palpable masses, you cannot see those over, telehealth. You can't feel them. You can't, see a breast mass. So there's certain things that everyone really has to take a step back and take a breath on telehealth, as it is a great, I don't want to say stopgap, but a great delivery of medicine with limitations, and realize that it's not a replacement for every kind of in-person care. Would you agree with that? Absolutely.
And coming back to, we started talking about the physician fee schedule final rule for Medicare. That is very clear. You can tell that's kind of their philosophy from how they've decided to what they've decided to do with the Medicare telehealth eligible list. And I should explain that real quick. So Medicare maintains a list of services that it covers as telehealth services. And if you just Google Medicare telehealth eligible list, you'll find a link to on the CMS website where you can download this list. And it's a zip archive file. And if you extract it, it's a spreadsheet you'll find where they list all of the CPT and HCPCS codes that are covered. And then very helpfully, they'll also say, is it temporarily covered during the PHE? Is it covered as an audio-only service, yes or no? And they actually update this pretty regularly. Like every couple of months, they'll have adjusted it. And the final category of telehealth codes under the fee schedule final rule was permanent additions to that Medicare telehealth eligible list. And it's actually a very small number of items that are being added on a permanent basis. So that means they're going to be there, regardless of whether or not there's a public health emergency. And it's things like group psychotherapy, home visits for established patients, and then only the lower levels of complexity for those, domiciliary rest home custodial care services, again, for established patients, like we were saying, because under normal circumstances, you wouldn't want to initiate a new patient into your care over telehealth because you cannot touch the person or really do a physical exam, like you were saying.
And one thing to clarify, too, that Grant was saying under the home health, I've had people say, well, isn't everything home health at the patient's at home? No, we're talking home health agency home care patients. So just be clarification on that.
Mm-hmm. There's another one that was in the final rule, which was the visit complexity code, the G2211, which there have been a lot of questions about. And that was going to be made a permanent telehealth eligible code, as well as a code you could append to an in-person visit. And that code was tabled until 2024 because people just couldn't figure out what you had to do to get paid for a complex visit.
I think it was also they needed to find $3 billion or something to be able to fund the 1 year fixed increase they gave us to the calendar year conversion factor. So they're like, well, let's just delay this thing since nobody knows what to do with it anyway.
Yeah. What they ended up doing, as you point out, is delaying that implementation freed up all the money that was going to be allotted to pay for the utilization of this code, because CMS had said they expected this add-on code, G2211, to be billed with up to 90% of office outpatient E&M visits. And I think it was, if you look at the national average, it was this code was going to pay like $15 per visit. So if you're telling me 90% of office outpatient E&Ms are going to pay an extra $15 for over the entire Medicare program nationwide, that explains why the initial Medicare conversion factor was so low. It was like, I think, a 10% drop from the previous year. And then at the last minute, as part of the stimulus bill that was signed by President Trump before the new year, they delayed this code and then took the money allotted to it and redistributed it to make the conversion factor drop much lower.
Right. And then also I think that the one thing is, everybody, I hope that you see that already, even though the conversion factor is still lower than last year, the RVUs for E&Ms really increased. I mean, almost 20% on some. So,
right.
Because the whole point of, and I don't want to get into an E&M 2021, that's another story, but since a lot of people are still using them under the PHE, remember that the reason you're getting so much more money for them is because the thought process over patients over paperwork is that you're spending more time with the patient. Not that now that you don't have to do the whole bulleted point history and exam, now you now have that time for patients. But I think what a lot of practices I'm seeing is now they're saying, now I've got more time to get another patient in. So there's some issues there. But I wanted to, just to get back to our topic here, I wanted to just ask your last question here. What do you think is probably the best tip for the day or the tip for the month for our listeners preparing for the future of telehealth, knowing that regardless of what happens, obviously the percentage is going to go down a little bit, but what should they do if they really want to keep a good percentage of telehealth in their office? What would be your tip on that?
Well, I think it's kind of in two parts. It's, again, assuming that telehealth has been successful for your practice and it's been embraced by your providers and patients. And we know that the answer is not necessarily yes for those questions. But if it is, and you think telehealth is going to be an important part of your service mix going forward, then the two parts are, well, first, look at everything that you're depending on waivers for right now and assume the waivers go away. And so you're going to have to do research about whether you are inside or outside of a metropolitan statistical area and therefore would or would not be able to comply with the originating site rule. Look at how, if you are eligible to be an originating site, how you would fill out the paperwork you would need to get approval from CMS to deliver telehealth. Look at the HIPAA rules and figure out what is a good HIPAA compliant platform to use once the OIG decides to stop being lenient with, consumer apps like FaceTime and Skype. Look at how you're marketing telehealth and telling your patients about it and communicating with them about it, because that's all going to be necessary when certain waivers go away. And then I think the second piece is look at the compliance. What's your policy right now on obtaining consent for telehealth services? And, you're using an annual form and you're getting the patients to sign those every time. Are your providers properly documenting for telehealth visits? And that, that's its own can of worms, but obviously, you don't want them to be copying forward physical exams that are impossible to do over telehealth. It's one of the things we've seen as a problem when we audit telehealth services. Even if they're doing away with the exam as a requirement as part of the 2021 E&M guidelines, you don't want incorrect stuff appearing in notes. And certainly if it's not a service that's going to be billed under those guidelines, you are going to have to worry about the history in the exam. And I think, as you mentioned, Terry, the OIG is already beginning to audit telehealth services and looking to see, are you documenting? Was there real-time video as well as audio? What was the platform used? And all of those things. So from a compliance standpoint, you have to be prepared. And from a, what's gonna stay and what's gonna go away standpoint with the waivers, you have to prepare.
I agree. And I think the other things that I would just tell our audience or our listeners, really what I would do too is I would survey your patients, especially based on your patient population, your specialty. Ask them specific questions when it comes to telehealth. Did you like it because it was convenient, because you didn't have to park, you didn't have to drive to the office? Or did you feel like you got a clinically appropriate visit out of it? That's the first thing. And I would also put on that survey, if you have an out-of-pocket, for those that are commercial plan and don't have to pay an out-of-pocket, but if you have to pay a share of cost, will you pay for it once the public health emergency ends? And I think the last thing you need to look at is, what's your primary way of delivering telehealth to your patients? Audio only or audio and video visit? Because remember, the audio only will go away in almost every payer except for maybe one code. And we still have virtual check-ins, but those are worth very little money. So those are things you have to really consider as you do your due diligence for the future.
I think those are great points, Terry, and speak to the practice management side of it, which is so important.
Right. Well, again, thank you, Grant, for participating today. We appreciate having you on the show and your insight into this hot topic of telehealth in the healthcare industry. And hopefully we'll talk to you in the near future.
Thanks, Terry. It was my pleasure.
That's it for us today, everyone. Please join us next month, March 9th, for our discussion with the NSCHBC Healthcare CPAs and the provider relief funds, and making sure you're compliant with reporting and accounting for all the money that's been pushed out, the PPP and the HHS funds, and making sure now during tax season that you're appropriate in your reporting. So everyone, make it a great day, a great rest of your month, and thank you for listening to the NSCHBC Edge podcast.
Thank you for listening to the NSCHBC Edge Podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.